Squamish and Tsleil-Waututh, as well as the Métis communities of the Lower Mainland region, and all of you, wherever you are in this province or around the country, speak to, especially this weekend, and thinking of Monday as National Day of Truth and Reconciliation, reflecting on your contributions to truth and reconciliation. Next slide. So Province-Wide Rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. We also are grateful to all of our industry partners and all of you in the various health authorities who contribute to both the uptake and the generation of new knowledge that helps us take better care of patients across this province and country. Next slide. So, that's the wrong slide, but can you maybe take that down, and I'll just introduce Janine. So Dr. Janine Farranger is an assistant professor at the Department of Occupational Therapy and Science at the University of Toronto. And she's a recipient, actually, of the Canadian Research Chair for Tier 2 of Life Participation in Kidney Disease, which I think is a huge recognition of her contributions to the field. She's an occupational therapist and has taken a rehabilitative lens to look at life participation and its relationship to people living with kidney disease. And I think that this is a lot that we can learn from other perspectives. I've had the privilege of knowing Dr. Farranger as she was a Crescent fellow and then a new investigator. She holds more than $400,000 in Tri-Council training awards and is currently the new investigator award. She's also contributed to a number of national, international kidney care initiatives and developing a pan-Canadian CKD self-management tool, My Kidneys, My Health, and participates in Song PD and Song CKD. And so without further ado, Janine, I'll turn it over to you to help us with you explore pathways. So over to you, and thank you very much for making the time to be with us today.
Thank you so much, Adira. I really appreciate it. So thank you for having me today. I'm actually really excited to be able to take this opportunity to talk about life participation in kidney disease and really start to think about how we can move towards pathways to support life participation in our group of patients. And I actually want to start this conversation by talking a bit about a revolution that's been happening in nephrology research really over the past maybe 15 years or so. So traditionally, the direction and focus of research in nephrology has been set primarily by researchers. Researchers design the studies, researchers decide on the important targets for change and on the health outcomes that they're going to measure as indicators of treatment success. And this is the way that health research has traditionally been conducted, and the dominant way that research in nephrology has been carried out as well. But we had a bit of a revolution start, again, about 15 years ago, when there was sort of a collective reevaluation, both I think within and outside of Canada, about whether this was the best model. And the idea of patient-oriented research really started to emerge. So patient-oriented research means engaging patients, caregivers, and families as partners in the research process, and really prioritizing their voices and their perspectives. And this model has been redefining how we make sure that our research really matters and makes an impact at the end of the day. So this shift in philosophy sparked a number of really cool initiatives that emerged within kidney disease research. One of those that you might be familiar with is the CanSolve CKD network, which is really using a partnership-based model to conduct meaningful research that involves people with kidney disease in the research process. And another initiative that emerged from this patient-oriented research revolution was the Standardized Outcomes in Nephrology, or SONG initiative. And this is being led by a group out of the University of Sydney, but really it's a global project. And the goal of this project is to develop a set of core outcomes and outcome measures for clinical trials and for other forms of research in kidney disease that can really be used universally across the world. And the neat thing about this project is that those outcomes are being chosen based on the consensus priorities of patients, caregivers, clinicians, researchers, and other relevant stakeholders. So it really is a partnership-based approach to deciding research priorities. So the way that the SONG project has gone about this is to identify 3 tiers of priority outcomes to measure in research. The highest or most important tier being core outcomes, and those are chosen as being sort of critically important by all stakeholders. And the SONG exercise has been done in 8 different kidney disease populations involving people from 63 different countries. So this really is a big and wide-reaching project. So you wouldn't be off base for thinking that the outcomes that might emerge as being highly important would be the ones that we tend to think of in research and focus on in research: survival, kidney function, hospitalizations, infections, etc. But something really cool also happened, which is that this outcome that I don't know if people quite saw coming rose to the very top of that priority list again and again. And that outcome was life participation. So in the SONG kidney transplant group, the SONG PD group, the SONG kids group, the SONG GD group, life participation was chosen as one of those core outcomes, that top priority tier. And even in the kidney groups where it wasn't there, it was often mentioned as important in relation to other outcomes that were chosen, like fatigue, for example. And so I think this finding has highlighted that this is really something we need to think more about in kidney disease. And I personally was really excited to see that patients and stakeholders had highlighted this as being so important, because I am an occupational therapist, and supporting life participation is really the focus of what we do in our profession. And so the things that I want to accomplish today are to think about the importance of life participation to people with kidney disease, to talk about, all the range of factors that can affect their life participation, and then also to start to consider some potential pathways that might exist to promote life participation in people with kidney disease, some directions that we might be able to go with that. So first of all, what is life participation? A totally valid question. It's not really a term that we use in our everyday vernacular, but the patients came up with this term independently. And the SONG groups have defined life participation as the ability to participate in life activities that provide a sense of fulfillment, enjoyment, control, and hope. And this could include activities like working, studying, spending time with family, traveling, pursuing hobbies, enjoying recreational activities, and doing social activities as well. So they kept the definition very broad, basically just being able to do all of the things that you want or need to do in your life. And we've done some research to really support this kind of broad definition of life participation, because we found that people with CKD have a lot of different goals and priorities. In a study where we asked people on dialysis to set life participation goals for themselves, these goals span doing household tasks, being able to do self-care activities, hobbies, socializing, sports, and other things as well. So people with kidney disease really want to be participating more in a lot of different areas of their life. And I think that it's a helpful thing to recognize, because we've tended historically to place our focus, I think, at least in research, on the concept of being able to quote unquote function, which really sort of reduces that standard to, can you manage to get through a day safely? Rather than recognizing the importance of being able to thrive and do the things that bring fulfillment to your life as well. So this is a quote from the SONG PD report that I think really highlights that. And the statement was that the ability to participate in life activities was seen as the fundamental goal of their treatment, because it symbolized being able to live a life without being confined by the disease. And so this is really the aspiration of people with kidney disease, to realize their full potential, to avoid having their life being confined by their health in any way. So unfortunately, the data we have suggests that many people with kidney disease do currently experience some limitations because of their health. So when we look at data from the hemodialysis population across the world, this was data from the DOP study, for example, we can see that the percentage of people who are able to be totally independent with self-care activities Things like showering, managing medications, grocery shopping, is less than 1/3 in most countries. So many people are relying on others for help. And even in earlier stages of kidney disease, the likelihood of experiencing some type of limitation with performing self-care tasks is significantly higher than in people without kidney disease. So this challenge really does span the spectrum of CKD severity. We see this in employment rates as well. So people experiencing kidney failure, especially, have much lower rates of employment than the working age general population. In the US, a study found that employment rates were 26% in dialysis, 37% in pre-transplant, and 38% in kidney transplant recipients, compared to about 80 to 85% in the general population. So many people are not able to participate in the workforce either. And then thinking about the impacts on leisure and social participation as well. So people with kidney disease have described how joys in their lives are foregone, how they're unable to fulfill relationship roles. For example, in previous research, they've talked about, not being able to travel, to go out dancing, visiting friends, to go to the mall, play with their kids, or have a romantic relationship the way that they would like to. And so kidney disease really does appear to affect life participation in many different domains. So the million-dollar question, of course, is why? What are the barriers? And how do we identify those barriers so that we can start to work towards some tangible solutions? So in occupational therapy, we have a helpful approach where we think about there being three major kinds of barriers to life participation. And this sort of helps us to hone in on potential solutions. So the first is a person's personal capacity. People might not have the physical, cognitive, or emotional ability to participate in an activity. And they might not have the knowledge or the skills to compensate for those limitations either. The second type of barrier is environmental. The environment that the person is in, whether it be their physical environment, the social environment, the people that they have around them, or the cultural environment. The environment just might not be set up in such a way that it supports them doing the activity. So it might be a poor match with their skills and with their capabilities. And then the third type of barrier is the activity itself. So the demands of the activity that the person wants or needs to do just might not fit the person's capabilities either in the form that they are currently trying to do it. So just to think about an example, so say there's a patient in a dialysis unit and they say, I'm not able to prepare meals for my family anymore, and this is something that's really bothering me. So the reality is that this person could be facing a lot of different types of barriers to doing this task. At a personal level, they might be experiencing weakness, fatigue after dialysis, pain. They might have cognitive challenges. They might be experiencing depression, all things that we know are common in people with kidney disease. And those things could be interfering with their ability to cook for the family. And they might not have the knowledge or the skills to overcome those challenges. So the kitchen might not be set up in such a way that it meets their needs. Maybe it's inaccessible for them. Maybe it's inefficiently organized. It's causing excess fatigue. Maybe they need cupboards labeled or access to adaptive equipment. And maybe they also lack a social support system who could be there to help them with the task. And so those could be reasons why they're not able to cook dinner for the family. And then at the activity level, maybe the meals they normally cook are just too challenging now, given the other barriers that they're facing. Or it could be that trying to incorporate all the dietary requirements that you have to meet with kidney disease is just making cooking too difficult and too complex. So when we break it down in this way, you can see there are a lot of different reasons why people with kidney disease might not be able to do the life activities that they want or need to do. And I think recognizing the complexity of this gives us a lot of potential solutions to explore. And so this approach is really kind of the basis of what occupational therapists do. So I work full-time in research, and the goal of my research program is really to move us towards finding pathways to promote life participation in kidney disease. So this is something that we are better equipped to address in kidney disease care. And I have three sort of, angles that I'm approaching this from. The first is working on identifying research priorities for this area. So Again, life participation, I think, kind of came out of left field in terms of being a core outcome in nephrology. But now knowing how important it is to patients, the question we asked is, what do we already know about how to promote life participation in kidney disease? What research has been done that can guide us in this area? And are there interventions designed to do this at all? And the second question is, if there are interventions, what types of interventions are they? What barriers are they targeting? And are we overlooking any factors that could potentially be important? So I supervised some occupational therapy students in conducting a series of scoping reviews in 4 major kidney disease populations. So pre-dialysis, hemodialysis, peritoneal dialysis, and transplant. We looked in 6 electronic databases for literature. We were looking for any qualitative or quantitative study that examined some kind of intervention to address life participation in one or more of these kidney disease populations. And the way that we operationally defined that was just any study that had life participation as a study outcome, either primary or secondary was included. And our goal was, again, to describe patterns in the literature and identify research gaps that would really help us to set directions for where we should go in terms of what to study, who to study, how to measure outcomes, et cetera. So the first thing that we found was that promoting life participation has unfortunately not really been a priority in nephrology intervention research. You can see in this table that the number of studies that had life participation as their primary outcome was very limited. The largest body of literature was in hemodialysis, but generally there were just a really small number of studies that have looked at life participation as an outcome in all. And again, we included any intervention. It did not matter what type of intervention it was. We captured everything. So these were the total body of studies that had life participation as an outcome. So really small body of literature looking at it as the primary, and even the secondary, there really weren't a lot of studies. So just not much literature out there to inform interventions that we could be using to support this for our patients. The second thing that we found was that across all 4 populations, a lot of the studies that were done were of basically medically focused interventions. So things like medications, different dialytic approaches. And then most of the remaining studies were of exercise-based programs. But generally, the focus of all of these interventions was on improving people's physical ability to perform their life activities. What we saw very little of were studies targeting any of the other barriers to life participation. So addressing cognition, addressing emotional well-being, again, helping with skill building, any environmental changes that could be made, or activity-related changes. And so there were a lot of knowledge gaps, and really there just hasn't been a lot of work done in this field. And just as a rough comparator, what we see in other populations who, have complex health challenges and also experience disability. For example, in TBI and stroke, a systematic review was done in 2014, so 10 years ago, and it found that 491 articles just studied the impacts of cognitive rehabilitation alone. And that was in 2014 again, so the number would be higher now. So our literature base in kidney disease is extremely limited in this area. The types of interventions that we have are also sort of at odds with what people who have kidney disease have actually said that they want in a rehab program. So in one study, people talked about wanting, again, support to address psycho-emotional social needs, wanting a multimodal program design, wanting something that addressed their symptoms and incorporated symptom management strategies. And so really there's a lot of work we can do in this field to meet the needs of people with CKD and supporting their life participation. So I have done some work myself to start to try to identify mechanisms and treatments to address life participation in kidney disease. And one of the areas that I've looked at is cognition. So we already know that cognitive impairment is common in people with kidney disease, especially people on hemodialysis. However, we don't have a particularly good grasp of how much cognitive impairment factors into the life participation challenges that people with kidney disease or people on dialysis have. Again, we tend to focus on the physical limitations associated with kidney disease. So we know a lot less about how cognitive impairment, might affect people's ability to do things like pay bills, manage medications, cook, or do other life activities that are cognitively involved. So I have a graduate student who just completed a study involving 105 people on hemodialysis from 2 dialysis centers here in Toronto. And we asked participants to do 2 functional cognitive tests. So often when you're asked to do what you're asked to do during a cognitive assessment isn't very practical. So it could be, count backwards from 100, draw a cube, things that you probably don't normally do in your everyday life. And these things don't always accurately reflect people's ability to actually do their practical tasks. So functional cognitive tests are designed to look directly at practical tasks. And we use 2 tests called the MMA-A and the UPSA-B, which assess people's ability to pay a bill, schedule an appointment, and do a medication management task. And a trained observer scores the performance and notes any challenges that people encounter while they are doing these tasks. So what did we find? We found, first of all, that about 30% of people displayed significant challenges on the UPSA-B tasks, which were paying a bill and scheduling an appointment. And over 50% had challenges on the MMA task, which again was learning a new medication regimen. So functional cognitive challenges essentially were very common in our hemodialysis participants, even more so in the in-center dialysis patients than the self-care dialysis patients, which we expected. And when you consider the types of people who usually participate in research versus those who choose not to, these numbers are probably an underestimation of the true burden of functional cognitive impairment in our patients. So the Montreal Cognitive Assessment, or the MoCA, as it's often called, is a common cognitive screening test that we sometimes use in kidney disease care. And we found that it actually correlated fairly well with the UPSA-B functional cognitive test. So people who scored as impaired on the MoCA were far more likely to exhibit impairments on the UPSA-B functional tasks. And in fact, many people who were impaired on the MoCA did not have significant difficulty with the UPSA-B. So it was mainly when the MoCA scores got into the range of moderate to severe impairment, so in that below 20 range, that we started to see impairment in the UPSA-B functional cognitive tasks as well. So I think this study helps to highlight the potential impact, again, that interventions like cognitive rehabilitation could have for that 30% or more of people who did display evidence of functional cognitive impairment. Again, cognitive rehabilitation, it refers to an evidence-based set of approaches that can either restore cognitive functioning or more often help people learn to compensate for their cognitive deficits. And so I think these results really demonstrate a need to explore these types of interventions in people with CKD as a way, again, to support their life participation. So another area that I have done some work in is fatigue and how we minimize the impact of fatigue on our patients. We know that fatigue is the most common symptom of kidney disease. For example, it's been estimated that up to 70% of people on dialysis experience a significant fatigue. And it's very prevalent in other kidney disease populations as well. In a study done here in Canada, fatigue was chosen as a top 3 research priority of people on hemodialysis. And in the US, patients identified fatigue as the most important physical symptom to find better treatments for. So it really is a widespread and sort of unaddressed issue. And we also know that it has a profound impact on life participation. In the SONG initiative, people on hemodialysis really talked about how the impact on their everyday life was the worst part of their fatigue. So I've done some previous work to develop an energy management education program for people on dialysis. So energy management is an approach that's about using strategies to help conserve energy and be as efficient as possible as people are going about their everyday tasks. So in the program I developed, we talk about 7 key sort of energy saving strategies, which are eliminating a task that isn't really a priority, is finding ways to simplify a task, using assistive tools to help do a task, organizing the environment, for example, again, labeling cupboards, putting things in easy reach, asking someone to help out with parts of a task, finding a different position to do the task in. So for example, sitting on a stool while you cook, or slowing down a task, breaking it up into chunks, for example. So in the energy management program I developed, which is called the PEP program, people learn to apply these strategies by completing 3 short web modules and then having 4 to 6 sessions with a trained clinician to apply the strategies to their personal life situations and goals. And we found that the program was potentially effective in a pilot randomized controlled trial. So the people who completed the program were far more likely to achieve their life participation goals. At 3 months post-intervention, we found that more than 60% in the intervention group had achieved those life participation goals compared to just 25% in the active control group. However, the major challenge that we have with the PEP program is one of implementation. So we interviewed the nurse coordinators who we had trained to administer the intervention during the study about their experiences doing that. And they experienced some significant challenges. For example, with using an evidence-based problem-solving strategy that we incorporated into the program to help it be effective. We also listened to some of the session recordings to further examine the intervention fidelity. And we found that while, again, some of the core facilitation strategies of the program were consistently used, we found that others were not. And this was, again, after our nurse coordinators had undergone considerable training. And I think, the reason for this essentially is that this type of program is typically administered by trained occupational therapists who've studied these approaches for months, even years. And the nurse coordinators just didn't feel qualified to administer the intervention. This was something that they expressed. So I'm currently in the early stages of planning a project to modify the PrEP program so that it can be completely self-administered by patients. This is a bit of an experiment. Rather than having individualized sessions with a clinician, patients would complete the program on the computer, and there would be a little bit of tailoring, although of course not as much as they would get if they were actually working with a person. But we want to see if that would be effective at all to sort of solve this trained personnel problem that we have in the dialysis units. And if this works out, stay tuned. It would be potentially an easy resource to give to patients that could be helpful in supporting their life participation, but we still do not know whether this would be effective or not. So we'll have to stay tuned for that. So then the final piece of this overall puzzle that I'm trying to tackle in my research program is developing measurement tools that can accurately capture life participation in people with kidney disease. Again, so that we have a way to identify people who need further support, and also a robust way to measure the effectiveness of interventions. So I am a member of the SONG PD and SONG CKD life participation working groups. Again, those international research groups that are working on this area. We did 2 scoping reviews to look at how life participation is usually assessed in people on PD and people with pre-dialysis CKD. And really, we found that there was no consensus best practice approach. And really, there was wide inconsistency and heterogeneity in how this construct was measured. And the most frequently used instruments were subscales of quality of life measures, measures like the SF36, the KDQOL, SF, or the EQ5D. So these are just like examples of where you do see life participation being touched on in those measures. So for example, the EQ5D does ask 1 question about problems doing usual activities. And then the SF36 has a few more questions. It asks about the impact of both physical and emotional health on work or other regular daily activities. I think the limitation of these subscales, though, is that they were not constructed with as much rigor and attention to detail as dedicated life participation measures should be. Again, they're not designed to measure life participation. They're designed to measure quality of life. And so it would be, I think, like trying to assess depression using a quality of life screen. It's just not designed for that, although it captures a sort of related construct. And there are not many measures that have actually been validated in people with kidney disease either to assess life participation. So we don't know if these measures capture the issues that are most important to people with kidney disease with respect to their life participation. So really, we're lacking the tools to measure life participation in a way that we can trust and rely on. So I have been working on two semi-related projects to help us move forward in this area. Again, the first is developing and validating brief outcome measures of life participation with the song groups. And then the second is validating the PROMIS social participation measure in people with kidney disease. So for that first goal, the song groups have been working on developing brief assessments of life participation that have actually been co-developed by people with kidney disease to really be sure that they capture what is important to our patients. So these tools are great as screening tools to identify people who may need further assessment and further follow-up. They're also great outcome measures for clinical trials to take a look at how interventions are affecting life participation. And again, that was something that we didn't really have before, a valid tool to use for kidney disease. The Song PD and Song KT life participation measures are already publicly available. They can be found through the Song website. So if you're interested in accessing those and using them, they are already available. So the second goal that I have been working on is validating a very robust existing measure of social participation for use in people with CKD. So the measure is called the Patient-Reported Outcomes Measurement Information System Social Participation Measure, or PROMIS-SP, which is definitely easier to say. So the strengths of the PROMIS-SP are that it's thoroughly validated, it's highly reliable. It focuses on social participation more in depth as well. So it's a great follow-up measure to learn more in patients who are, again, screened as maybe having difficulty in this area. It's also individualizable, and it can also be used to compare social participation with other diseases for research and advocacy, since it has been well validated in so many different populations. So I have worked with a team in Toronto on validating this measure, first in kidney transplant recipients. And the tool has been found to be very valid and very reliable in that population as well. So I think it's a useful tool for kidney transplant recipients. And we are looking to validate in the dialysis population as well. So that's some of the work that we've been doing in my research program to try to identify, again, pathways to promote life participation in kidney disease. But I think it's worth pausing to note that we do continue to be constrained by the lack of trained rehabilitation professionals in CKD care settings, who I think could be doing so much more to address this issue of life participation with our patients. So this is a slide that I show my occupational therapy students in their very first week in the program. And they learn right up front that the entire purpose of OT is helping people to gain access to, initiate, and sustain life activities that they need or wish to pursue, how, where, when, and with whom they wish to pursue them. And our students then spend 2 years studying how to promote participation in occupations, which to us, occupation means all life activities, not just your career. So when we talk about occupation, we mean work, education, social participation, self-care. And we really do have access to a tremendous amount of evidence-based intervention approaches that could make, I think, a real difference for people with kidney disease, although we do need more research to support that. So this was a set of guidelines that was recently developed about the role of a specialist renal occupational therapist. And it really outlines, again, some of the things that we could be helping with. For example, recommendations for adaptations to the home environment, vocational or job-based rehabilitation, supporting people with home dialysis by doing environmental assessments and task analyses, cognitive assessment and rehabilitation for sure, seating and postural assessment. So these are all services that kidney patients really should have access to. And yet a review just came out from the UK. Unfortunately, we don't have a similar study from Canada as of now, but in the UK, they found that of 42 kidney care hubs that they surveyed, only 22% offered any form of outpatient rehabilitation services. And of that, only 7% of dialysis units did, 9% of pre-dialysis CKD care programs, and 7% of kidney transplant programs did. So really, unless you're hospitalized and you're an inpatient, you're usually not getting access to rehab support as a person with kidney disease. They also found that the scope of services provided was really limited when it was there. So less than 20% of kidney hubs offered intradialytic exercise programs. Again, this was in the UK. Only 22% provided rehab-based symptom management support. Less than 10% offered support with meaningful activity during dialysis. Less than 5% offered direct support for, again, life participation in activities outside of dialysis. And again, the top 4 reasons for having such limited support were, of course, number 1, lack of funding, lack of time among the existing staff, just prioritization of other services, and a lack of qualified personnel for this role. And so again, I think when we think about this quote from one of the participants in my studies, which exemplifies, as we've seen, how a lot of people with kidney disease feel, he said, trying to get back to your normal life is the hardest thing. I'm in a state right now just because I can't do all those things anymore. I can't be me. There's a lot that slowed me down. And so I think maybe this, speaks to how it's time for us in CKD care to really rethink how we provide services and advocate for services that will meet sort of this really important need of our patients. So I would just like to thank all the organizations and people listed on the screen for their incredible support in my research and my career. And I would be happy to take any questions now.
Yeah, thanks so much, Janine. We've got different ways to ask questions. As I said at the beginning, either raise your hand or put it in the Q&A. I just want to thank you for it's very timely, like we're all talking about how you want to improve outcomes for people with kidney disease, and outcomes for the patients means that they're living their life, and we give lip service to it. But I think the advent of tools that we can easily use, both to measure as well as to address, like to help to facilitate, I think is going to be a huge step forward. So thank you for the work that you're doing in that arena. I think it's great. This whole notion of life participation is something that all of us appreciate. And I think that some of the tools that you're talking about would be really great to operationalize them. And instead of asking generic questions, we use these tools, and then we have some substantial way to measure what the answers are. And then if we do an intervention, how to fix that. Exactly. So that's great. I guess I also want to ask perhaps a bit of a sensitive question, which I may or may not know the answer to, but in terms of cultural appropriateness of some of the tools that are out there, usual activities, like whatever that means, but
100%.
That could be generic, and that it could be anything to anyone. On the other hand, I'm thinking about, our Indigenous groups, our people who don't speak English, who come from other cultures. I don't know how they would answer that. I don't know how well validated some of the tools are. Yeah, no, it's a great question. On a bit of literacy. Yeah, it's a wonderful question. Actually, I'm right now teaching a course in our program on assessment methods in occupational therapy. And one of the things that we're really talking about recently is, again, the cultural appropriateness of our measures, and how we make sure that, I think a lot of our measures are grounded in and come from sort of really culturally and Western biased perspectives. And so that's something that we're grappling with within our profession as well, is how do we address this? And I think, some of the screening tools that are used, these really brief sort of measures that we have, there's maybe sufficiently broad that they can just capture, because again, they don't really zero in on what activities you're talking about. So really that the person is kind of, defining what that means for themselves. Although who knows whether people can relate to these terms and really know what these things mean. And so that's a question to ask for sure. But I think when you start to dig into, we have assessments we use where we start to ask people about their participation in activities that we expect people to be doing. And that expectation is really where you start to go, okay, well, what should I be expecting people to do? And who am I to expect people to do anything? And what is it? How do we make sure that those are not making assumptions that are not incorrect, and again, grounded in a certain perspective? Yeah. Yeah, and I guess, I was just reflecting, like, there's this one patient in CKD clinic whose GR is very low, and her family knows that she's okay when she's cooking. Like, as long as she's cooking, she's happy. And so if then that's how her participation is now. I wouldn't have thought that cooking indicated happiness. Well, maybe I would, because I do like to cook, but the point being that I think we have to tailor it and maybe have open-ended questions, like what makes you happy? cooking, great. How much of that are you able to do? Like trying to think of how to use
Absolutely.
things that you've just taught us
We have a
in
great measure that we use in OT
practice.
that really, I think, addresses that need quite well. It's called the Canadian Occupational Performance Measure. It's actually kind of like our standard sort of national measure that every OT uses. And it actually allows people to set their 3 life participation or occupational goals. And it's completely defined by them. So it can be anything. I mean, we had use an example in class yesterday of somebody who he used to be a college football coach, and his only life goal was to be able to use his remote control. That was all he wanted to be able to do. So, and his wife we were talking about, his wife was not thrilled that was his one goal. He had a lot of other challenges, but that was it. But that was the goal that went on the measure. And then we set, so it's a standardized, it's a quantitative measure. So then we get them to rank how important that goal is on a scale of 1 to 10, how well they currently feel they're able to do that thing on a scale of 1 to 10, and how satisfied they currently are with how well they're able to do it. And then, so that is then used, and it's been shown to be a valid outcome measure we revisit once we've done the therapy. And so that's one way around it. Really just let people define it for themselves and then sort of go based on that. And I think, yeah.
Yeah, no, I think that's important. I guess also the concept of how satisfied are you on a scale of 1 to 10 is also a very Western way of quantifying things.
Yeah.
And so that's the other thing that I think to be a bit cognizant of is like, everybody quantifies 1 to 10,
Yeah,
very happy, not happy, like whatever it is. But I think it's great, and it's really important work. And I really want to thank you for taking the time to give us this talk and have us rethink about this as we go about our clinical work, but also for the research that you're doing, especially in the kidney space, because as you said, there's not a lot of people in the kidney space.
Yeah.
And hopefully this becomes more and more normalized. So yeah, thank you so much for putting in the time. Oh, there's a question that popped in as we were talking. Curious about the renal facilities that have OTs on staff. Are there any in Canada? Do you see kidney renal programs starting to prioritize OT to support life participation?
Yeah,
it's
a great question. So I can only speak. So again, unfortunately, we don't have a published study. This study just came out of the UK, which was great. And I feel like doing the same study in Canada, because when I talk about this, I'm only talking about my personal sort of, perceptions of what I think are available based on what I've seen and talked about with people, etc. And again, my sense is that it's the same in that renal patients certainly have access to OT when they are inpatient. So when they are admitted to hospital, they have access to OT to help with discharge. But again, there is no sustained support. And unless you are admitted, you don't have access to these kinds of supports and services, again, to do sort of that more sort of bigger picture, long-term life planning. Like, okay, how do I adjust to having kidney disease, being on dialysis, all the symptoms that I'm experiencing? How do I live well with this? And in inpatient services, they're not providing that kind of intervention because it's a much more focused, again, let's just get you home kind of thing. And then again, because there's no outpatient OT, they're just not having access to this unless they're getting it from somewhere else, unless they're getting it through their, a non-renal setting, unless they're connected in another way. But again, I don't think, my sense is that I'm not aware of renal programs that have outpatient OT in Canada. Yeah.
Yeah,
I don't know, Adira, if you have any thoughts on that.
I think there are rehab facilities, and there might, I would say like that there might be some like OT programs associated with rehab, outpatient facilities or inpatient, but certainly not dedicated to kidney patients, except maybe, I think Vanita did or didn't. Vanita
yes, she did.
Or didn't have OT.
She did, yeah.
But that was a very specialized program for frailty and for older adults, etc.
Yeah.
So I think it is something for us to think about and or upskill all of us to be aware, because some of these things are useful for ourselves or our elderly parents or someone in daily life. And so the more we all socialize the need to at least ask these questions, and then we can advocate for the appropriate healthcare professionals to be involved in our teams. I think that's a really good point. Yeah, I think that's a great place to leave it. And again, thank you very much for the
you.
time, and for all of you for participating, and happy Friday.
Yeah, thank you,
Thanks.
everyone. Take
Thanks so
care.
much.